Hello, my name is Dustin Flannery, and I am a neonatologist and clinical researcher at the Children's Hospital of Philadelphia and University of Pennsylvania in Philadelphia, PA. Today, I'll be speaking about maternal and neonatal protection from COVID-19. Here are my disclosures. The objectives of this talk are to discuss how does COVID-19 affect pregnant patients and newborns? Should pregnant women get the COVID-19 vaccine? And lastly, how can newborns be protected from COVID-19? Let's start with how does COVID-19 affect pregnant people? But before we talk about how the virus affects pregnant people, it's important to understand how often are pregnant people even infected with COVID-19? I will discuss studies we performed on seroprevalence of the virus in our community. Seroprevalence studies are basically studies of antibodies in a population. Such studies are an important component of the public health response to COVID-19. Viral testing data, such as PCR, may underestimate mild or asymptomatic cases. And assuming all exposures result in an immune response, these studies may be a more complete reflection of community exposure. This immunity within a community can help us estimate overall community viral exposure. For these studies, we collected residual sera obtained for clinical purposes that was scheduled for discard after maternal birth hospital discharge. Sera samples were de-identified and transferred to our research laboratory, where they were tested by ELISA for SARS-CoV-2 IgG and IgM antibodies to the spike receptor binding domain antigen. We also collected limited clinical data from review of electronic medical records. During the early pandemic preliminary period, April through June 2020, we enrolled 1,293 women who delivered at 2 Penn hospitals and had available sera specimens. 80 or 6.2% of the delivering women had IgG and/or IgM SARS-CoV-2 specific antibodies on admission. During the same period, there were 23,160 cases reported in the city of Philadelphia, which has a population of nearly 1.6 million people, suggesting an infection rate of 1.4%, which is more than 4 times lower than the estimates based on our serological data of women presenting for delivery during that period. We found striking and statistically significant race and ethnicity differences in seroprevalence rates during this preliminary period, with higher infection rates in Hispanic and Black women of about 10%, compared to 2% in white women and less than 1% in Asian women. We continued enrollment after this preliminary period, and in the study period to date, spanning from April 2020 through February 2021, we've enrolled almost 8,000 women presenting for delivery. Of these, 93% had available sera, and 845 women, or 11.5%, were seropositive, with detectable IgG and/or IgM, as shown in the study flow diagram. The proportion of women who were seropositive almost doubled since the preliminary period. 56% had detectable IgG only, 5% had detectable IgM only, and about 39% had both detectable IgG and IgM. The characteristics of the study population are shown here, broken down by the total cohort and seropositive and seronegative groups. Women who were seropositive were younger and had higher rates of obese pre-pregnancy BMI when compared to women who were seronegative. There were no significant differences between the two groups in maternal diabetes, hypertensive disorders, mode of delivery, preterm delivery, or live-born infant status. The moving average of overall seroprevalence during the study period is shown here, as the black line and 95% confidence interval in gray shading. Time is on the x-axis, and percent seropositive is on the y-axis. There was a statistically significant increasing trend over time with a p-value for trend of less than 0.001. As you can see here, we were not able to account for difference between infection and vaccination status in this data. We found that the seropositivity rate remains higher among Hispanic Latina women and Black non-Hispanic women compared to white non-Hispanic women and Asian women. And while there is statistically significant increasing trend over time for each group, the gap between different race and ethnicities remains. In conclusion, seroprevalence rates in special populations, such as pregnant women, can provide insight into the exposure in a community. Overall, 11.5% of parturient women delivering at 2 Philadelphia hospitals from April 2020 through February 2021 had evidence of SARS-CoV-2 antibodies, with more recent rates surpassing 30% and increasing trends in seroprevalence over time, which may be due to increasing infection or vaccination, or both. We found race ethnicity differences in SARS-CoV-2 exposure, identification of factors that contribute to these differences, including systemic racism, may inform public health measures aimed at preventing further infections. While our study assessed virus exposure among pregnant women in the community, other work has assessed whether or not pregnant women are at higher risk for severe COVID-19 disease. It is well known that during the 2009 H1N1 flu pandemic, pregnant women were generally at increased risk for severe disease, including disease leading to hospitalization, admission to an intensive care unit, or death, as compared with non-pregnant women and the general population. Pregnant women accounted for about 5% of deaths, despite accounting for only 1% of the population. So, knowing that physiologic and immunologic changes during pregnancy increase the risk of infection severity from other respiratory viruses, namely influenza, there were legitimate concerns about the effect of COVID-19 on pregnant women early on. Now, a year and a half into the pandemic, we've started to analyze data from a number of sources. An analysis of 77 cohort studies published last September made clear that pregnant women are a high-risk group for COVID-19. The review included data from more than 11,000 women with confirmed or suspected COVID-19 and who were hospitalized during their pregnancy for any reason. The odds of a pregnant woman with COVID-19 diagnosis being admitted to the ICU were 62% higher than for non-pregnant women of reproductive age. And the odds of needing invasive ventilation were 88% higher. The risks of other morbidities, including maternal mortality, preterm birth, and NICU admission, also appear to be higher, although there are conflicting reports. A CDC study echoed these findings. The study included more than 400,000 women with a positive test and symptoms of COVID-19, of whom 23,000 were pregnant, and found similar increases in the odds of ICU admission and invasive ventilation in pregnant women. The CDC continues to track data to date on COVID-19 during pregnancy, and as of this week, October 11th, 2021, they have reported a total of over 128,000 cases in pregnant women and 180 maternal deaths. Internationally, the effects of the pandemic on maternal outcomes has been assessed, including in a recently published systematic review and meta-analysis in Lancet Global Health. And while the studies included thus far are likely a limited picture, a clear signal has emerged, particularly in low and middle income countries, where there's an increased odds of stillbirth and maternal death. I think it will be some time before we fully know how the pandemic impacted these and other important outcomes, and it's very likely that the impact may be different across various settings and regions. Let's switch gears now and discuss how COVID-19 affects newborn infants. Practical questions from newborn care providers emerged early on in the pandemic, such as, how should neonatal care providers protect themselves? Should new mothers with confirmed or suspected COVID-19 be separated from their newborns? Do newborns born to infected mothers require testing? Can infected mothers breastfeed? And how should infants with possible COVID-19 be cared for in the NICU setting? And what criteria should be used to discharge such infants to home? Although evidence was accumulating to inform adult care, relatively few data were available to guide neonatal care when mothers were infected. Yet, neonatal clinicians and obstetricians were faced with this on a nearly daily basis. The early recommendations from the American Academy of Pediatrics Committee on the Fetus and Newborn provided some guidance, such as precautions for birth attendants and staff attending a birth when the mother has COVID-19. Importantly, they did recommend against rooming in for mothers and well newborns. While difficult, temporary separation was thought to minimize the risk of postnatal infant infection from maternal respiratory secretions in a time where it was unclear how infected newborns would be affected. For breastfeeding, it was recommended that alternate caregivers feed expressed milk. Guidance was also issued for NICU care, including how and when to use certain PPE, isolation, cohorting, unit visitation, and discharge criteria. You may ask, why were the initial recommendations from the AAP so conservative? Isn't the AAP supposed to advocate to keep mothers and newborns together under all circumstances? And really, the reasoning behind these recommendations relate to the 2009 H1N1 influenza pandemic previously discussed. Although data were available before 2009, suggesting that pregnant women were at increased risk for influenza-associated complications, H1N1 provided solid data on this vulnerability. Pregnant women with the 2009 H1N1 influenza virus were at substantially higher risk for hospitalization than the general population. Moreover, the 2009 pandemic H1N1 virus was also bad for babies. Infants born to women who had been severely ill with influenza complications had increased risk for adverse outcomes, such as preterm birth or small for gestational age. And of most concern, infants less than 6 months old who experience influenza virus infection have the highest rates of hospitalization and death of all children. In light of all this, the National Registry for Surveillance and Epidemiology of Perinatal COVID-19 Infection was created. This was a collaboration led by Dr. Mark Hudak at the University of Florida, who at the time was the chair of the AAP section on neonatal perinatal medicine. He and some of our collaborators at CHOP and Penn created a REDCap-based survey to collect de-identified information on mothers and newborns at sites across the United States. Initially, the registry focused on women who were SARS-CoV-2 positive within 14 days of birth, though it now also collects information if the woman was positive at any time during pregnancy. This initiative was supported by the AAP infrastructure and received funding through a contract with the CDC. Here are the data from late May 2021, about 14 months into the pandemic. There are data from almost 10,000 dyads in the registry from almost 300 centers across the United States. Again, the majority of women were asymptomatic on admission, which could reflect true asymptomatic infection or persistent PCR positivity after resolved infection. The race ethnicity breakdown is shown here, with a Hispanic predominance. About half of the women had roomed in with their newborn, and the newborn test positive rate remained low at about 2%. The data are not shown here, but importantly, the positivity did not differ between infants separated or roomed in with the mother. So what have we learned so far? Well, the highest risk to the newborn is among mothers with onset of illness within a week of delivery. The lowest risk is among those with onset of illness more than 1 week before delivery. Why is this? Potentially because the women are no longer contagious, or possibly related to the role of protected antibody, which we'll talk about shortly. Many women were tested per obstetric admission protocols, universal testing, not due to symptoms or exposures, and were probably not contagious at the time of delivery. This is potentially because many had infection remote from delivery with persistent PCR positivity. There seems to be no difference in overall risk with separation versus rooming in as long as infection prevention steps are taken, which was an extremely important observation. And so this was a really nice example of how evidence-based medicine is supposed to work. Real-time evidence was able to inform these important guidelines to allow neonatal providers to safely optimize care of mothers affected by COVID-19 and their newborns. In addition to tracking COVID-19 during pregnancy, the CDC also tracks positive testing for SARS-CoV-2 among infants born to pregnant women with COVID-19 in certain jurisdictions. Similar to the AAP findings, the rate of positivity among tested newborns suggests the incidence of newborn infection is quite low. Currently, such tracking cannot distinguish between vertical transmission before delivery and horizontal transmission of the disease during or after delivery. So in summary, for newborns, most do not become infected, and those who are usually don't get sick. However, some studies do suggest that the virus can cross the placenta, though this seems to be a rare phenomenon. Case reports continue to emerge of infants born with neurologic complications after maternal COVID-19 infection during pregnancy. And currently, it remains unknown how the virus can damage the placenta and cause indirect injury to the fetus and newborn. So we talked about how COVID-19 affects pregnant women and newborns, but now we'll discuss how can pregnant women be protected from COVID-19. Historically, pregnant women have been excluded from early vaccine trials. As this one editorial states, this is both unjust and imprudent from a public health perspective. Instead of protecting women from research, we should be protecting women with research. And with little to no data, the CDC early recommendations were understandably ambiguous. The CDC early on stated that getting vaccinated is a personal choice. Any of the currently authorized COVID-19 vaccines can be offered to people who are pregnant or breastfeeding. If you have questions about getting vaccinated, a conversation with your healthcare provider might help, but is not required. And so pregnant women early on were essentially left in the dark. The CDC did create a subset of their vSafe registry where participants who report pregnancy at the time of vaccination could be actively contacted to enroll in a pregnancy registry. As of last week, more than 163,000 vSafe participants have indicated they were pregnant at the time they received the COVID-19 vaccination, and more than 5,000 have been actively enrolled. The participants are contacted once per trimester, after delivery, and when the infant is 3 months old. Outcomes of interest include miscarriage, stillbirth, pregnancy complications, maternal ICU admission, and birth and neonatal outcomes. And importantly, these data are and will continue to be publicly available. So far, the preliminary data from the vSafe Pregnancy Registry, including about 8,000 women, which was recently published in the New England Journal, have been reassuring, finding no clear difference from background rates for pregnancy and neonatal outcomes. There are no red flags so far. Just last month, the CDC released a health advisory recommending urgent action to increase vaccination among people who are pregnant, recently pregnant, and those who are lactating, who are trying to become pregnant now or who might become pregnant in the future. This was a strong change in stance from the CDC, who now recommends that COVID-19 vaccination, either before or during pregnancy, strongly is suggested because the benefits of vaccination outweigh known or potential risks. The highest number of COVID-19 related deaths in pregnant people in a single month of the pandemic was reported in August 2021 in the United States, likely related to the highly infectious Delta variant. Despite the known risks of COVID-19, recently it's been reported that only 1/3 of pregnant people in the US are fully vaccinated. Finally, I will end with how can we protect newborns from COVID-19? We know that in general, newborn immunity derives from innate immune responses, maternally derived transplacentally acquired antibodies, and breast milk acquired immunity and protection. Most neonatal guidance around infectious diseases is centered on how maternally derived immunity protects the newborn. For instance, maternal infections at birth, such as varicella, and also ACOG recommendations for maternal influenza and Tdap vaccine during pregnancy to protect the newborn from influenza and pertussis before they're eligible for vaccination. Using this knowledge and the study framework I previously described, we scavenged maternal and cord blood sera after clinical use when scheduled for discard from April through August 2020. We collected clinical, serologic, and SARS-CoV-2 nasopharyngeal PCR testing data to determine factors associated with placental transfer of SARS-CoV-2 specific antibodies. Of almost 15,000 dyads, there were 83 women with antibodies, and 72 passed these antibodies on to their newborns. Of the 11 who did not pass on antibodies, most had very low levels of antibody and/or had been recently infected, likely not allowing for enough time for antibody development and transfer. Here we assessed antibody levels and transfer by maternal severity of illness and found that there was similar antibody response and transfer to the newborn, whether the mother had symptomatic, mild, or moderate to critical disease. SARS-CoV-2 IgM antibodies were not detectable in any of the 72 seropositive infants. The figure on the right demonstrates that IgG concentrations in cord blood positively correlated with maternal IgG concentrations, which is not surprising. Among the 11 cases where there was a seropositive mother and a seronegative infant, 5 of the cases, the mother was only seropositive by IgM without IgG, and we know that IgM generally does not cross the placenta. In 6 other cases, the maternal geometric mean IgG levels were significantly lower compared to the 72 mothers with seropositive infants. And among mothers with well-dated onset of illness and nasopharyngeal PCR testing, cord IgG was present in all cases if the onset of illness was greater than 15 days before birth, which makes sense. The mother needed time to create her own antibodies and then initiate transfer to the newborn. The figure here on the left demonstrates that the transfer ratio of IgG antibodies from the mother to the infant was positively correlated with days from NP-PCR testing to delivery. So, our study showed that women who are infected during pregnancy can and usually do pass antibodies on to their newborn. But can maternal vaccine provide newborn protection? Here is the first case report, but certainly not the last, that was published suggesting that a newborn had antibodies to the virus delivered 3 weeks after the maternal first dose of vaccine. At our centers, we have started to assess maternal antibody responses to vaccination in comparison with our prior work with women with a history of infection. Notably, these are raw antibody levels and not geometric means. But as you can see, our preliminary data here show that the antibody response to vaccine, both Pfizer and Moderna, is very robust in comparison to infection. Here the data are presented visually, and again, this suggests that the antibody response to vaccines is greater in comparison to both asymptomatic and symptomatic history of infection. As we would expect, antibody transfer from the mother to newborn is quite efficient. For women with infection or vaccination, as demonstrated by mean transfer ratios greater than 100% for all the groups. Here's the bottom line. Pregnant women with COVID-19 are at higher risk of hospitalization, severe disease, ICU admission, mechanical ventilation, and death. Newborns are infrequently infected with COVID-19. They can likely become infected in utero, although this seems rare, and it's more common to see infection of the newborn during or after delivery. Most newborns who are infected have mild illness, but severe illness does occur, and there are case reports across the globe of infants requiring ICU admission, mechanical ventilation, ECMO, and even infants who died. Pregnant women should discuss the risks and benefits of COVID-19 vaccine with their healthcare providers and understand more recent recommendations from the CDC that they should be vaccinated during or before pregnancy to prevent severe illness and to protect their newborn. So what changes might you make in your practice? 1, counsel mothers with COVID-19 infection that the risk of newborn infection is relatively low, around 2.5%, when infection prevention steps are taken. Inform pregnant women that COVID-19 antibodies from both natural infection and vaccination cross the placenta. And lastly, be aware of the differential impact of COVID-19 infection on pregnant patients. For more information on this subject, Please see the following publications which were discussed during this presentation. I thank you so much for having me at this conference and for listening to the presentation of the results from our recent COVID-19 studies, and I now welcome any questions. In addition, I thank the conference organizers for having me, including my division chief, Dr. Eichenwald, and my research mentor, Dr. Karen Popolo, for their contributions to this presentation.